But I can tell you, after more than 20 years working in many countries around the world, what I have realized is to confirm what Danny Sakas published a few years ago, that at the end, the egg decides if a woman gets pregnant or not. It's the egg. The old Romans used to say, life comes from an egg. And we men have to admit, we have not much to say. At the end, it's the egg which decides if you are going to be pregnant or not. So it's important when we stimulate a woman that we make sure that we don't damage this egg, because at the end, this egg is the source of pregnancy. Now, when we stimulate a woman, obviously we don't want to have few eggs. We don't want to have too many eggs. We want to have a certain number of eggs in order to be successful. Now, some people have published papers saying, look, the magic number is 15. If you have 15 eggs, everyone is happy. I would absolutely disagree with that, by the way. I don't like huge databases because there is a lot of heterogeneity and you dilute a lot of issues which are hidden in this data. And you know, that was not the first paper from the Netherlands. This paper came out that, yes, 15 is the magic number. But then I would ask you, 15 for whom? 15 for a 20-year-old, 30-year-old, 40-year-old, or 45-year-old. So 15 is not equal. The next question would be, how was the stimulation done? How was this patient stimulated in order to get these 15 eggs? Would it be possible when we stimulate that patient that we jeopardize the quality of this egg? We published this paper a few years ago in Human Reproduction stating the more the better. So maybe 15 is not the correct answer. And this is another paper which was published a few months ago in FNS. And as you can see also here, what they clearly demonstrated, the number of eggs is directly linked to higher pregnancy rate. So basically, the more eggs you have, the higher is the pregnancy. But how many eggs do you need? So the first question would be, for whom? To have one child, to have 2 children, 3 children. Let's say you have 15 eggs, you are between 30 and 34. So you see 15 eggs, 30, 34, 80% chance of having a kid. But what if you have 15 eggs and you have 41? 41, as you can see, you see the number 15, the chance is maybe 30%. So 80%, 30%. Why is that? Simply because you create more genetically abnormal eggs. That's the nature of a woman. There is an aging process of the eggs. So 15 is not equal 15. Why? And here you see the difference between men and women. You see, with man, you don't have any abnormality. So there is future for Ivan and myself. Even when we are getting older, still we can have healthy children, chromosomally. But with women, you see, this is not the case. So you see, you have more maternal meiotic abnormalities. Now, there is something, it's called a threshold concept. So basically, every woman has a different threshold. And when you recruit those follicles, you don't want to have too many, you don't want to have too few. So basically, you want to capture a certain amount of the eggs. But the egg is one thing. The receptivity of the uterus is another thing. You see, when I speak on a conference, there is one sentence that I love to use, and some of you might have heard it before. Do you know that the uterus of a woman is the worst place for an embryo to be in? It's a funny sentence, but it's a true sentence. And I heard that sentence, I think 2002, 2003, when I was in Belgium. Claire Bourguin, who was a pathologist in Belgium, she told me that. And I was laughing at her when she used that sentence because I didn't understand it at that time. The uterus of a woman is the worst place for an embryo to be in? Yeah. Why? Because in a cycle of 28 days, it's only receptive for 2 to 3 days. And you might have the most beautiful embryo, and you put it back outside these 2 to 3 days, you will fail to have an implantation. So it's utmost important to synchronize the embryo with that endometrium. And initially, we were very simplistic. We thought, oh, look, there is a window of implantation, and the window of implantation is maybe 4 or 5 days. And I think that is not fully correct. We are also simple. You know what we do? We put the scan, we look at the endometrium, and we say, this is a beautiful endometrium. It's like you want to buy a car and you look at the car from outside, but you don't check the engine. Still, it's a beautiful car. But how is the engine? So this is important not only to have a superficial view, but also to have a more in-depth assessment. Endometrium is extremely complex. There is an interaction of so many things in order to create that so-called window of implantation. Now, this is a very old and simple study, but I think it's a very powerful study. And this is from it's 50 years old. Actually, it's from 1950s. So you can calculate. It is now more than 74 years old. What does it say? You see, every line that you see here represents a day of a cycle. And as you can see in the luteal phase, every day, every single day, you have changes of the endometrium, which you cannot visualize on the scan. Now, these changes occur obviously through changes of endocrine profile. More recently, from Carlos Simon's group, and I think this is a very, very nice study, it looks like a modern art, but I can explain you. Basically, this is the gene expression of the endometrium in the proliferative phase, late proliferative phase, the patient ovulates. Even with the ovulation, when progesterone is coming out, nothing is changing. Nothing is changing. But after 120 hours, suddenly you have a downregulation. And this is your window of implantation. Then you have a downregulation again. So this is a powerful slide. This is showing that it's not the progesterone exposure itself. It is the time of progesterone exposure which is important. So progesterone exposure is preparing the so-called window of implantation. And we know that the endometrium of a natural cycle and stimulated cycle differs significantly. We know that the endometrium of a woman who has been stimulated is always advanced. If I would ask you, why is the endometrium of these women advanced? Most of you would say is because estradiol is high. And this is what I have learned when I studied. But today I can tell you it's wrong. It's not because estradiol is high. It is simply because we trigger those women. So when you trigger a woman who has been stimulated, your progesterone shoots up immediately. Within 1 or 2 hours, you have a progesterone exposure. So that is why the endometrium is advanced. And if it is advanced by more than 2 days, as you can see here, you will have no pregnancy. So it's important to understand progesterone is preparing for the window of implantation, and progesterone is the hormone which is impacting the so-called secretory transformation to prepare this window of implantation. Now, we know from all studies that the moment your progesterone starts going above approximately 1, you start changing the secretory transformation. So the change starts, but the gene expression for implantation doesn't change until approximately 120 hours. And this is the time where your window of implantation is opening. Now, this is a paper we have published 2 years ago where we looked, why is the endometrium advanced? And as you can see, you know, all of us are worried about the progesterone on the day of trigger. We are measuring estradiol, we are measuring progesterone, and we say, okay, if it is less than 1, we are happy. But did you ever measure the progesterone 1 hour or 2 hours after the trigger shot? This is what's happening. So let's say at 6 p.m., the progesterone is 0.8. Everyone is happy. You trigger at 7 p.m. At 9 p.m., your progesterone is 1.6. It doubles. So it means your endometrium is immediately exposed to progesterone. So you initiate the secretory transformation, so you misplace or displace the so-called window of implantation. And obviously, this is another paper we have published when I was in Belgium with Inge van Varenberg, where we demonstrated that the gene expression changes the moment your progesterone goes up. Now, progesterone goes up, I don't have to tell you, pregnancy rates drop. In every single patient, pregnancy rates drop, obviously, in a fresh cycle. Now, you might say, I don't care. I'm going to freeze those embryos. I'm going to freeze those eggs. I'm going to put it back in a subsequent cycle. The bad news is that apparently there seems to be also negative impact on the egg quality. So it's in our interest to prevent this progesterone going up, because if the progesterone goes up, it's a sign that we are doing something wrong. It's a sign that we are possibly jeopardizing the quality of the egg. And this is what has been published on many occasions. This is a paper we have published, I think, also 2 years ago, or 1.5 years ago, where we demonstrated also more genetically abnormal embryos if you have high progesterone during the stimulation. Also from Brussels, Christophe Bloquel and Annalisa Racca published a couple of papers demonstrating the same. Now, let's go back to basic physiology. What happens if a woman is being stimulated? The follicles grow. The bigger those follicles become, the more progesterone they produce. So bigger follicle, more progesterone. Simple. And some people, in order to promote certain drugs, said, look, the progesterone is going up because we are not giving enough LH or ACG. This is the so-called megaset study published also almost 20 years ago. You see, they said, look, progesterone is high because we are not giving any ACG. But what they have neglected is that they have triggered at a significantly bigger size follicles. Remember, the bigger the follicle becomes, the more progesterone it produces. So it's simply, this is how you should not do science, because you have here suddenly 2 variables. Actually, you have more variables, but I'm going to come back to that. So this is one study, the way it should not have been done. Now, if you look at the molecule of FSH, it's a very complex molecule. It has 4 arms or 4 legs, the yellow parts that you see in the picture. And each one of these arms or legs can attach up to 4 sugar residues. What do these sugar residues do? The more sugar residues you attach to the FSH, the more acidic it becomes. So it changes the isoform of that FSH. So higher glucosylation, more sugar residues, higher acidity of that molecule. And the higher acidity, basically, it's called salivation. It changes the isoelectric point of that molecule. And by changing that, obviously, you are changing the half-life time of that molecule. So if you have no sugar residues, you have here, LH has very, very few sugar residues. ACG has something, it's called carboxy terminal peptide, 28 amino acids, which makes it very acidic. So hence, you have a very long half-life time. Now, if you take a look at REC-FSH, it's a very basic form. Urinary is more acidic, and coripolyltropin alpha, because it has the CTP, 28 amino acids, it has a very long half-life time. Now, if you take a look at the acidic form should have longer half-life time. The basic form should have lower half-life time. But if I would ask you, is urinary more potent or recombinant? We know that recombinant is more potent. Why is that? It's very simple, because what you administer is what you get. There is no batch-to-batch variation, as we know, but that is not the only difference. The other difference is extremely important, is that it has a very high affinity for the receptor. So the recombinant FSH, it's pure, but it also has a high affinity for the receptor. And that's also another variation that we need to look at. So those group which came out with the idea that maybe ACG is preventing progesterone rise, because that's what they have said, it's preventing progesterone rise, they did an RCT, and they stratified the patients in 4 groups. One group had no ACG, one group received 50 units of ACG, one group received 100 units, and one group received 150 units. So in their mind, they thought the more ACG they administer, the lower should be the progesterone, because they thought ACG is preventing the premature progesterone rise. And guess what? Exactly the opposite came out. The more ACG they administered, as you can see here, the higher was the progesterone value. And it's logic, because LH is not preventing progesterone rise. ACG or LH are promoting the progesterone rise. So studies comparing, for example, administration of LH to FSH, they did not demonstrate any difference. And these are important studies. LH is contributing to progesterone rise. As you can see in the first line, you see the higher the LH receptor expression, the higher is the progesterone. The higher the LH values, the higher your progesterone values. So LH or ACG are not the reason that we have progesterone rise. What is the reason? And this is something we started looking at also 12, 15 years ago with Dimitra Kirou, and we published this paper. It seems somehow related to the FSH and the way we stimulate women. Now, we know that FSH by itself is inducing LH receptors. The more FSH you give, the more LH receptors you create. And the more LH receptors you have, the more progesterone you create. So somehow it seems to be linked to the FSH receptors that we are creating. So a lot of FSH, especially towards the end of the follicular phase, creates a lot of LH. And LH is the reason why you have premature progesterone rise. And that has been validated and reconfirmed by other groups based on what we had published in the past. Now, what happens when you stimulate? Obviously, your FSH is accumulating. So when you go towards the end of the follicular phase, you add FSH, you add FSH, you add FSH, and there is also an accumulation of that FSH. So basically, this is what is happening. You add FSH, but actually, this is what nature would have done. It would have created a multifollicular recruitment. Nature would do monofollicular recruitment, but it could use the same pattern. But towards the end, the FSH would go down. So we are doing something wrong during our stimulations. And this was the first pooling question. And most of you did not answer it correctly. Why is that? Simply because towards the end of the follicular phase, you have less FSH receptors. So the bigger the follicle becomes, the less FSH receptors you have. A follicle which is 10 to 12 millimeter, it's a small follicle, has only 50% FSH receptors. A follicle of 15 millimeter has almost no FSH receptors. It's mostly only LH receptors. And those LH receptors are there for the final oocyte maturation. As you can see, at the end, there is no need for too much of FSH. So basically, we have looked and published few papers looking to systemic progesterone values. And what you see is the more FSH you give, the higher is your progesterone. Now, this study was published in Human Reproduction in different groups, step down towards the end of the follicular phase. If you are a poor responder, normal responder, high responder, it has an impact. And the more FSH you administer, the more is your systemic progesterone level. This is a very interesting study. If you take two women with the same demographics, same BMI, same AMH, everything the same, you give them same dose of FSH at the same time, and after 6 days, you give the antagonist to suppress her own FSH, and you measure the systemic FSH present, you will see that one of them, with the same dose at the same time, has a systemic FSH of 7, and one of them has a systemic FSH of 27. So even the same dose might be different because the absorption and the clearance among these women is different. This is why we have published this paper that maybe it's time to start also measuring the systemic FSH. Systemic FSH during stimulation is one thing. The basal FSH is also important. So this is what we presented at ASRM, but the paper came out 2 months ago. So the full paper came out recently. Also, the basal FSH is important. There is a difference if your basal FSH is 4, 5, 6, or 7, or 8, or 9. So every simple step increase of basal FSH has an impact. And I'm not going to go into depth due to time issues, but also the FSH receptors, the polymorphism of FSH is also extremely important. You see, based on the receptor that you have, whether it's aspirin, or serine, your endocrine profile, your basal FSH levels will differ significantly. Your estradiol per follicle will differ significantly. And you know, this paper, which we published also recently, looked also to the basal FSH levels on the day of starting stimulation and FSH levels on the day of trigger. The higher the FSH on the day of trigger, the more aneuploidy you have. Now, some studies compared, for example, different drugs. They compared, for example, folitropin delta with folitropin alpha. One group, it was individualized. The other group, it was not individualized. And you know, you need to individualize and do dose adaptation, because if you don't do this dose adaptation, you will harm the outcome. It's like you put a car, which is very potent, you start driving full speed without looking what's going around you. And I think this is important, that you need to individualize the starting dose, and you need to individualize during the stimulation in order to harvest the better quality oocytes. Studies have confirmed that if you individualize the treatment according to the patient's requirement, you significantly improve the outcome. And these are also 2 more studies which came out from Asia, actually, and they did again the same mistake. They did not individualize the treatment according to the patient's requirement. So basically, when we speak about individualization, it's not only that you start a dose, it is the dose you start, it is the dose adaptation, it is maintaining the systemic endocrine profile within a certain limits, it's triggering at the correct timing, and I did not elaborate on the timing and the size of follicles due to time restrictions. But I think that's also another topic to see what size follicles do we have to trigger the dose and dose adaptation. So to conclude, I think today we have reached the era of individualized medicine. It's not one size fits all. Progesterone is an indicator of how good or how bad we are stimulating. And the progesterone itself is not detrimental because you can also do a luteal stimulation. It is the source of progesterone which is important. Where does it come from? And that is going up because you are giving too much of FSH, especially towards the end of the follicular phase. Too much of FSH, at the end of follicular phase, you have less FSH receptors. There is no need, but you have high levels of FSH. And that will create more LH receptors. If you have too many LH receptors, you are accelerating your nuclear and cytoplasmic maturation. Hence, you will end up with possibly more genetically abnormal eggs and embryos. And also FSH receptor polymorphism. I think there is much to do based on the basal FSH, which we have neglected, because the moment AMH came, we all jumped on AMH and forgot totally the old and good FSH. So I think it's also time to look more into the basal FSH. If you're interested, some books that we have edited and published over the past few years, where we highlight and describe the current findings. Thank you very much for attention.